Well, good afternoon, everyone, and welcome to the second of the Royal Statistical Society's Covid-19 evidence sessions, this one focused on government's statistical resources. I'm Gavin Freegard, your chair for today's event, ably assisted by my co-chair, Simon Briscoe, a member of the RSS Covid Task Force. You can find more details about that online. Simon will be keeping an eye on the online chat. Good afternoon to all of those of you joining us virtually, while I will be steering proceedings. As you may know, the UK government has announced an independent public inquiry to examine the UK's preparedness and response to the Covid-19 pandemic and to learn lessons for the future. It'll be chaired by Baroness Hallett. The Scottish government has also announced a public inquiry, hence the multiple governments leading to the apostrophe where it is in today's title. In order to inform those public inquiries, the Royal Statistical Society is organising a series of evidence session events to stimulate discussion about the issues that arose concerning statistics and data during the pandemic, to identify areas of consensus, and to highlight areas worthy of further investigation by the public inquiry, as well as helping the RSS to shape its own submission. We think that's particularly important given the draft terms of reference for the Hallett inquiry, which the RSS thinks could make more explicit mention of data and statistics. Today's is one of 4 RSS evidence sessions, one already held, focused on government communication during the pandemic. You'll be able to watch that on the RSS website shortly. And 2 to come will focus on how evidence and decision-making informed policy, and on the evaluation of interventions and policy. Today's evidence session focuses on the statistical resources available to different governments in the UK and explores 5 areas in particular. The first area is the data journey. Where did the data come from and how did it get to where it needed to go? What did that journey look like at the start? How did it change? And what drove any changes in public and private data availability and use? The second area is cross-government sharing. Did different public sector institutions, including central government, devolved governments, local government and health services, share and integrate data effectively across organisational boundaries? If not, what were the barriers? And what effect did that have on communication with policymakers, Parliament and the public? The third area is around definitions and communication. Were definitions and their caveats, for example, in how deaths or hospitalisations were defined, sufficiently consistent and clearly communicated? And how were any changes managed? The fourth area is based around the COVID infection survey undertaken by the Office for National Statistics. What can we learn from that survey and others conducted during the pandemic? Did it provide value for money? Were there alternatives? And what should its future be? Unfortunately, we're not able to hear from the ONS about the COVID infection survey today, but Ruth Studley from the ONS will be talking about it at an RSS event on social surveys and COVID-19 next Tuesday evening. Again, full details on the RSS website if you'd like to sign up. We'll be hearing from some of those behind other major surveys and sharing some other reflections on the ONS survey this afternoon. And the fifth major area is open data and transparency. How might greater transparency around data and research use in policy and decision making have improved outcomes? What could have been done to improve transparency? So that's what we'll be talking about, and here's how the event is going to work. First, we're going to have 4 10-minute talks from some excellent speakers, some of them here in the building and some of them joining us remotely. We'll then have a chance to discuss those presentations and put some of your questions, whether you're here in the building or joining us online, to the presenters. So please use the online chat if you're joining us virtually, and your hands if you're here at the RSS. We'll then have a number of 2 to 5 minute talks from some other excellent speakers, again, some of them here in the building and some of them joining us online. There'll then be a further opportunity for questions too and discussion with all of our speakers before we wrap up at 6 p.m. I'm told we may even mute people who don't stick to the time they've been given, so I hope all of our speakers have their stopwatches ready. Some housekeeping before we get underway. This event is being recorded, so everything everyone says will be on the record. If you're online, please do use the chat function on Microsoft Teams to share your thoughts and any questions you might have, as those will feed into our 2 slots for questions and discussion. This is only the second hybrid event of this scale that the RSS has organised, so please do bear with us if we encounter any technical challenges, especially since we have more speakers joining us virtually this time round. And if there is a fire alarm, there is not a drill planned for today, so if you do hear a fire alarm here in the building, please follow the fire marshals and exit the building. If you hear a fire alarm while you're watching at home, I suppose that's up to you in terms of what you do. Do let us know about anything you think we could improve for next time round. And if you're on social media, the Royal Statistical Society is on Twitter at RoyalStatSoc. Sorry, I'll try that again, at RoyalStatSoc. And you might want to use the hashtag COVID Inquiry. So we begin with 4 10-minute talks tackling different aspects of the statistical resources available to governments during the pandemic. Those 4 talks will be given by Ed Humphreys from the Office for Statistics Regulation, Dr. Adam Kaczarski and Dr. Ros Ego from the London School of Hygiene and Tropical Medicine, Scott Heald from Public Health Scotland, and Barbara Bodinier from Imperial College London. So our first speaker today will be Ed Humphreys, the head of the Office for Statistics Regulation, the regulatory arm of the UK Statistics Authority, which ensures that statistics are produced in a trustworthy way, are of high quality, and provide value in serving the public good. Ed, over to you.
Well, thank you very much, Gavin, for the introduction, as my notes go flying. Thank you very much, Tony. I hope that's not taking out of my 10 minutes. That's all I can say. Good afternoon, everyone. Really good to be here, and very much looking forward to both the remarks of the other speakers and also the discussion. I'm going to think about statistical resources, and I'm going to take both a slightly narrow and a very broad perspective on that question. The slightly narrow bit is that I'm going to focus on, I suppose, my area of responsibility, which is official statistics produced by the UK's 4 governments. That means I'm not going to talk about all of the excellent statistical resources available from non-government producers of statistics, which were so incredibly impressive and important. My not mentioning them is not in any way to not recognise their importance and significance. And I know we've got some speakers who will address them later, which I think is really very good. So that's a narrow bit. The wide bit is I'm going to define resources quite broadly, and certainly more broadly than a classic sort of idea of money and people. I'm going to sort of widen that out to think about other ways of thinking about the resources available. I want to start by saying, of course, thinking about statistics in the pandemic, there are a lot of successes. There were some tremendous dashboards, which certainly by the end of the pandemic were incredibly informative at very granular levels. There was a huge amount of information to a public that was very thirsty for information, statistical information. There was a lot of information to inform decision makers. We had a world-leading infection survey. So lots of successes, and I think it would be churlish to deny that. But I'm going to argue that those successes came sort of in spite of resource limitations. And in fact, in a way, the story of the pandemic for statistics and data was a series of successive resource limitations which had to be overcome. Some of those external to statistics producers and some of those internal to them. And that's what I'm going to talk about. Now, it might seem quite odd for me to say I thought there was a limitation in resource, given the lavish level of resources given to, for example, test and trace or the COVID infection survey. But this is where my wide definition of resource comes in, because I'm taking resources not simply to be the number of people, statisticians, analysts who are put onto COVID work, nor the amount of money being put into the collection of data, both of which are very impressive. I want to start my story of perhaps limitations in resources with data and data gaps in particular. So the pandemic threw up a whole series of data gaps. I'm going to mention a few which were progressively addressed, and then more gaps emerged, and then those were addressed. It was a sort of a constant cycle of limitation and then further limitation. So right at the beginning, there was a complete absence of community testing. To be tested as somebody with COVID, you had to be sick enough to be in hospital. That's clearly something which was spreading rapidly asymptomatically, a huge data gap. That data gap was corrected and culminating in the infection survey run by the ONS. Another data gap was data about care homes. We know very early on that there was a tremendously negative impact on care homes, a series of care home outbreaks, And it took some time before there was really good information about infection and mortality in care homes. Vaccines, always being seen as a tremendous success, the vaccine rollout, but actually right at the start of the vaccine programme, there were huge limitations in the granularity of the data available on who was getting vaccines and where they were and what their socioeconomic characteristics were. All of those gaps were eventually addressed, but I think that meant that given decision points, there were limited statistical resources available at that point in time. That's the data gap. The next element of limitation, I suppose, is even if there were data available, how widely shared and interlinked were they? And again, the answer here is one of, at the outset, very clearly problems with data sharing and data linking. If you read parliamentary evidence from members of SAGE, they will say right at the start, attempting to model the pandemic, one of the struggles for the modelers was just getting access to data. Since then, that limitation has been addressed very effectively by things like the COVID data store in Scotland. We're going to hear from Scott Hill later, he might mention that. The local data stores in England, the health data research, public health data asset. And there's a degree of optimism in the statistical community that latter success in data sharing might become the norm. And then, of course, we have the example of the GP data sharing attempted in England, which might suggest that it won't be as easy to generalise from the COVID case to broader data sharing. A further resource limitation, capability limitation, was around data frameworks. I think this is just as important as the data themselves. Just to take the example of deaths, measuring a COVID death or describing or defining what is a COVID death was unclear, or multiple options were available at the start of the pandemic, and it took some time before the current range of statistics that we have to be settled into a clear framework. So what we now have is an idea that there's a quick measure, which is every death 28 days after a positive test. We have a weekly registration measure, which comes from the death registrations, ONS, National Records Scotland, and NISRA in Northern Ireland. And then we have what's seen as the gold standard, but takes slightly longer, the excess deaths measure compared internationally. But it took some time to shape down all of the various numbers which are flying around about deaths into a coherent framework. And I think that limitation in terms of data frameworks that I've picked around deaths, there are other examples of it. And then there's a sort of broader and softer sense in which I thought resources had to evolve and develop, and that's the resources of organisational, and I struggle to find a good word here, mindset, or I'm trying to avoid the word culture because I think that's a fairly lazy term, organisational clout almost. So if you look at the landscape of statistics producers at the start of the pandemic, in terms of organisational clout across the UK, you saw a very different picture. In Scotland, you had an entirely new public health body, Public Health Scotland, which came into existence on the 1st of April 2020. Had a lot of new ambitions and new kind of energy put into it. In England, you had a Public Health England, which was well established, but somewhat at arm's length from government, reporting into a Department for Health and Social Care that itself was not particularly strong in terms of statistical expertise. In Wales, you had Public Health Wales, a strong body. In Northern Ireland, you had some good statistical teams, but rather limited in resource. That landscape has changed, particularly with the Department of Health and Social Care. At the start of the pandemic, it only produced one official statistic and it had no head of profession for statistics. It now produces many, largely as a result of absorbing the public health responsibilities of, or the public health analysis responsibilities of Public Health England as a head of profession. I think that shift in the department's centre of gravity is really important and positive for the long term. And an even softer element of organisational capability is, I think, mindset. So I've said that there are really good examples of data, and data story was positive. And everybody, of course, during the pandemic, in a policy role, became an enthusiast for data. But I do think the mindset differed from place to place. And I'd like to demarcate three tensions within that. The first tension is between data and statistics that are useful for communicating predetermined, pre-decided decisions versus communicating for transparency, so people are informed and can decide. And we saw that tension come out a lot, for example, through what is communicated through government announcements and speeches and so on. Is this being done to make as much information available as possible for everybody, or is it being done to communicate a determined policy decision? That's one tension. The second tension is between operational delivery and evaluation. Are you collecting data, for example, through test and trace, in an attempt to improve and refine your management of a big operational delivery, or are you doing so to aid evaluation? I'd be fascinated to hear Sheila Bird's comments on that. I think you've given a lot of thought to that. I'm giving the sign to wrap up, so I will wrap up by just simply saying one final thing, which is the challenge between transparency and explanation. And I think there are some examples where that became a tension, for example, around vaccine effectiveness. So there we have it. Process of successive challenges met very well by the statistical system, challenges of the resources available for data. And my closing remark is, whilst this is a story of success overall, I do worry that we might see a system that snaps back into its former structures unless organisations like mine and the RSS keep and encourage and goading continual improvement. Thank you.
Okay. A fantastic overview to get us started. We now move on to our second 10-minute contribution. That comes from Dr. Adam Kaczarski, Professor of Infectious Disease Epidemiology, and Dr. Ros Ego, Associate Professor, both from the London School of Hygiene and Tropical Medicine, who were involved in modelling COVID-19, and they are joining us virtually. So hopefully, Adam and Ros, you can see and hear us, and hopefully we're about to see and hear you as well.
Yeah, I can hear and see you. Okay, hopefully Ros as well.
Yeah, can you see the slides?
We can, yes.
Yeah.
Okay, so we'll make a start. So we'd like to provide an overview of some of the types and timelines of key data, their benefits, their limitations, and some of the lessons that this can point to. So first of all, it's worth emphasising that as well as UK data, there was a lot of benefit from international data throughout this period, and particularly early on, some international data sources that gave us a sense of the extent of missed infections and implications for things like fatality risk. So the Diamond Princess early evacuation flights, very useful for narrowing this down. And as we've heard early on in the UK, a lot of cases were being missed initially, and a couple of data sources that provided a useful indication of that undetected transmission was, first of all, the sentinel swabbing in GPs in the community, and then CHESS, which is the COVID hospitalisation in England surveillance system that linked together critical care admissions. So these were really some of the early indications that the epidemic was far further along in the UK than some of those early case numbers were suggesting. Now, the challenge with having things like hospitalizations is those are infections that have occurred perhaps 2 or 3 weeks earlier. So if you have control measures go in, that's not going to give you a very quick signal of what effect that control is having. So post-lockdown, it was actually social mixing data, things like the COMIX study, that provided that early indication of the extent that the behaviours changed and transmission might be coming down. We also saw in that period, Quad UK, the Genomics Consortium, come online that initially provided an indication of imported cases in that early epidemic, a lot of importations from France, Italy, Spain, often before those countries had actually reported outbreaks, but later would obviously come into its own as variants of concern emerged. We also saw the emergence of antibody data, initially from blood bank studies, which gave a really useful indicator of how much exposure there had been within the population and the relative contribution of perhaps immunity versus that behaviour change and control. We also saw, in terms of a better understanding of ground truth prevalence, the ONS study and REACT-1 start to come online. And then it's also worth noting there are a number of really useful healthcare worker cohorts, for instance, like Siren, that tracked reinfection and immunity dynamics within those populations. And then as we saw variants of concern emerge, these different data sets were very helpful for piecing together both what was going on, but then also just the characteristics of those infections and potential implications. And then as we saw vaccine rollout, a lot of the PCR testing that had been put in place could then be repurposed for very useful ongoing vaccine effectiveness in different groups. And as Delta and Omicron emerged, really having those different data slices provide very timely information on the characteristics and what it might mean. So I'll hand over to Roz now for a bit more detail.
Thanks, Adam. Yeah, I just wanted to talk a little bit about the types of data that were available early on. And so as Adam touched on, a lot of the uncertainty at the start of the epidemic came because we didn't understand yet the natural history of infection. So that's shown just by these little figures at the top here, the time to symptoms, the time to death, and the fact that those are distributions, not set intervals. And so that uncertainty in these time distributions was absolutely critical for percolating through the uncertainty into the modeling. Also, you see the little pyramid of severity there. So if you observe a death, initially it was very uncertain what that represented in terms of the number of severe hospitalized cases you would see or the number of infections that were out there for every death that you observed. And Adam touched on these lagged indicators. So if you observe deaths or if you observe hospitalizations, not knowing these time distributions very well means that you have to go back, you have to work your way back through all of this uncertainty to reconstruct what might be happening with the infections at the time. And we found with COVID, these are very lagged indicators. There was quite slow, quite long time periods to hospitalizations and deaths. And so as things progressed, as data became more available, you started to see some infection data available rather than purely disease, which will give you a sooner picture of what's happening. We also found that having enough of these kinds of data source to stratify, for example, by age or by location, for instance, if different hospitalization, different hospital care is happening in one place than another. It took a long time for these data that would allow stratification by age, location to become available. And then laterally, by vaccine status. So how does it change by vaccine status? And indeed, how does it change by variant? And so down this figure on the bottom, at the beginning, there's very little data available and the data quality are not very good. And as time goes on, more and more things become available, which is actually critical for research. But we just have to remember that initially we're in that bottom quadrant with a lot of uncertainty and a lot of clarity. And a lot of that comes from the roots of collection of these data, which is what I'm going to touch on here, which is that the different collection routes of the data we were analyzing, especially early on, came from, for example, active surveillance, so contact tracing and testing of those contacts, or seeing if they had symptoms, was very important. And then passive surveillance was where a lot of these early data came from. So symptomatic testing or counting of hospitalizations, as well as the real importance of indirect surveillance. So Adam mentioned evacuation flights, really critical, especially early on in giving an understanding of the size of the epidemic in the source location, but also remained important for this genomic sequencing, so that when people arrived from countries which may have had less sequencing into places with higher, then you could see what variants were circulating there. And so the difficulty of these is that we don't always understand the observation process, which has to be incorporated into all analyses. Whereas later, when design studies came on board, for example, community surveys, or Adam mentioned the healthcare worker studies, you are much clearer on the observation process, and that makes analysis easier and helps to cut down on that uncertainty. But one thing I think was very, very important early on, and probably will be important going forward, was that crowdsourcing was incredibly important in the early stages. So this is members of the public generally participating in collating data, translating data sources, and contextualizing these international data. So both finding them on public health websites and seating them within the public health context of that location. And this is important not just for epidemic data, but also for metadata and non-case data such as interventions. So helping to understand if data are collected, who they're collected by, and under what interventions, for example. And this became critical as the epidemic progressed, and the volume of data became larger, the number of countries affected bigger and bigger, and the resolution was such that research teams couldn't do this on their own. And I think the public sharing of these collated data with traceability, so very often on GitHub, with references, allows you to use them and trust them and understand the limitations a bit better. So I think that's important going forward. And then I'll hand back to Adam.
Thank you. So just to bring that together into some lessons, I think the first one is that reliance on lagging indicators, things like hospitalizations and death, for your situational awareness really hampers your ability to understand epidemic growth, and as well, a number of countries get caught out. We also had a lot of uncertainty early on in just the characteristics of the infection, its biology, whether it's things like pre-symptomatic transmission, fatality risk, and it doesn't just affect your estimate of that specific question, it also impacts all of the downstream analysis you might do of possible scenarios and control. We also had, throughout the pandemic, a number of situations where there were different hypotheses for a particular dynamic. If cases are surging, is it just because of behavior change? Is it because of characteristics of a variant? Is it something with waning immunity? So having complementary data that can allow you to distinguish between those explanations is extremely valuable. We also saw that it's important to bear in mind what question we're trying to answer with a particular data set. So in particular, if there's an assumption, say early on, that there's not widespread community transmission yet, it may be a relatively small data set that can allow you to test that assumption. Whereas if you want a very precise estimate of local prevalence, you're going to need something much larger. So different data obviously tailored to different questions. We also, though, did see a number of missed opportunities for good data insights. In particular, the enormous amount of travel testing that's happened that could have provided really unique insights into global prevalence by looking at cases coming in. But that wasn't done because it wasn't linked up. It wasn't made available in that way. And I think that's a real pity. The final point, though, that I think is worth making, looking at the timeline of these different data sources, is that a lot of the value of data sets wasn't immediate. A lot of these data systems were designed for one purpose and then really came into their own for something else. And so one example would be variants of concern. Having things like contact tracing and genomics really allowed understanding of the specific characteristics and what it might mean for epidemics, similarly as vaccine rollouts happen. So I think we need to be aware when talking about use of data and their value, not just on the questions we've got in mind now, but potentially the future ones as well. So we'll leave it there, and thank you.
Adam and Ross, thank you very much. That was bang on 10 minutes as well. Thank you. We now move to our third 10-minute speaker. It's another virtual one, and we're joined by Scott Heal, the Director of Data and Digital Innovation at Public Health Scotland. As you've already heard from Ed, Scotland's lead national agency for improving and protecting the health and well-being of its people. So Scott, thank you for joining us. Over to you.
Thanks very much. I hope you can all hear me and see the slides. I've got my stopwatch. So I'm going to try and keep to the 10 minutes I said there. So great to be with you all virtually. I'm Scott. I am one of the directors in Public Health Scotland, and I'm also the head of profession for statistics. And what I'm going to do is kind of talk you through kind of our experience of dealing with COVID from a statistical and data perspective as a new body, and kind of how we handled that in Scotland. So I'm going to touch on quite a few of the points that Ed made, but obviously give it from the perspective of being, I guess, in the thick of it, delivering during the pandemic. So going on to my next slide, in terms of just kind of introducing the resources available in Scotland, I thought it was really important just to kind of set the context of kind of who the main players, who the main bodies are in Scotland. So the setup is a wee bit different to other countries in the UK. And I guess by being a smaller country, we can do things in a more kind of joined up, streamlined way because of the size of the country. So again, as Ed highlighted, Public Health Scotland, a new body created in April 2020. You may recognise some of the bodies that formed Public Health Scotland. You've got ISD, Health Protection Scotland, and a body called NHS Health Scotland. Many people in Scotland think we were created because of COVID, but we were actually created to tackle a whole range of other public health issues, and COVID was our present on more or less the first day. Just to put it in context of size, around about 350 analyst statisticians in the organisation. But I'm going to look at the resources in a wider context, because we have a lot of data management expertise, a lot of epidemiologists, clinicians and programme managers, all of whom are really, really important to our success. And we worked really closely with the Scottish Government. They have their own health and social care analysis teams and analysts working in policy directorates. And what was really, really important for all of us was that joint close working, so that we were making the best of the collective resources across all of our organisations. And the other major body was National Records for Scotland, who focused on deaths data. And again, good coordination between Public Health Scotland and NRS on the release of death statistics. So just in terms of how COVID statistics are released in Scotland, or maybe I should say were, because it's all about to change. Daily stats published every day at 2 p.m. So Scottish Government and Public Health Scotland coordinated. High-level figures published by the Scottish Government, and more detailed breakdowns available in Public Health Scotland's COVID dashboard. And we also released all of the data as open data, so people could take it and use it for their own purposes. Public Health Scotland also had a weekly report bringing together more of the narrative about what was happening, so stuff that you can kind of take stock of week on week. That you are able to do on that kind of frantic daily reporting cycle. We had a range of special reports, including things like the evaluation of shielding. And really importantly, we coordinated again across all the bodies. So daily statistics were published at 2 o'clock, and the weekly reports from all the organisations were published at 12 noon each Wednesday. And that was to ensure that all the data was in the public domain, so that the First Minister, if she was using it in her statement, other people had access to all the information that she had. So in terms of reflecting on our data journey and how it changed, some lessons to learn, I think, from this. So initially it was high-level numbers that were being reported. It was very manual. There is talk, if you talk to our epidemiologists, we did actually have a whiteboard. We were counting on a whiteboard the number of cases coming through. And the epidemiologists were working separately from data managers and statisticians. And as case numbers started rapidly increasing, we rapidly moved to having new teams with cross-organisation and cross-professional working. We did move people rapidly into COVID, and that did mean that we had to stop some other work. So just to kind of highlight, although we have quite a lot of statisticians within Public Health Scotland, they were all doing other work, but we were able, because of the scale, to direct people from other work onto COVID pretty quickly. And that did mean that some of the statistical series that we usually publish were reduced or stopped for a period while we focused on COVID. And the reason why the cross-professional working became essential for us was that we were using data managers to effectively manage and link the data. And Ed mentioned the COVID data store that we've got in Scotland. So in essence, all the testing, vaccination, hospital, death, contact tracing, you name it, data about the pandemic was all in one place and all linkable. And we were able to make use of that every day to rapidly turn around the daily need for reporting. The statisticians did the analysis, so the analysis for the daily dashboard, the analysis for the weekly report. And it was really important that we linked in with the epidemiologists and clinicians to get that kind of clinical and epidemiology view of what was going on at different stages of the pandemic, and helping us inform kind of where the analysis should go. So really, really important that we had that kind of cross-professional join up. The other big thing for us was automation. So reproducible analytical pipelines were introduced for all of our COVID work. They weren't there at the start, so it was pretty manual, pretty stressful every day producing the figures. But automation became key to daily delivery, and in essence now it all runs automatically, and when the analysts come in the morning, all the data sitting there ready for reporting. So that's been a huge lesson for us, and something we're using in other work. Just to highlight, it was 7-day working, and initially at the start it was the same people working 7 days a week for weeks on end, and then when it became clear that COVID was going to be with us for quite a while, we changed ways of working so that we always had 7-day cover, but people weren't expected to work more than 5 days in a week. I'm not going to dwell on this, but just to flash up an image of our COVID dashboard. 50 million hits so far in the last 18 months. Just to compare that with some of the traditional PDF reports that we produce in Public Health Scotland, which get anything between kind of 4 and 100 hits when they're released. So this is really focusing our minds about how we share data and statistics going forward. So real lessons to learn from the pandemic about how people consume and use data and statistics. So again, just to kind of talk a wee bit about the data journey and how it changed, management information was produced by Public Health Scotland for government, the NHS boards and other stakeholders by 10 o'clock each day. And as I say, that's all automated now, so it's pretty slick. And that information became the daily and weekly public reporting. So we were really clear from the outset in Scotland that if ministers or Scottish Government officials were going to be using data in the public domain, that data had to be published in the public domain so people could see where it came from. And I think by and large, we handled that pretty well. Open data is released every day, so people can take it and do their own things with it. So we've got the UK COVID dashboard used our open data from Scotland. And there was also an individual called Travelling Tabby who created his own dashboard. And I think I can probably say his dashboard was better than ours. But that's another great reason why having open data is good, because he was able to lift that every day and turn it into his dashboard. And that really helped get messages out about what was happening around COVID. We also had a joint data and intelligence forum that was co-chaired by the government and Public Health Scotland to ensure that we were joined up in all the changes to reporting and ensuring that all decisions were made by statisticians and epidemiologists. And I think really importantly, Ed touched on statistical leadership. Statisticians had or have the final say on what was published and when. And I can remember vividly watching one of the First Minister's statements when she was pressed on a particular data set. I can't remember what the data set was. And her response was that she would have the data at the same time as everybody else when the statisticians said it was ready to be released. So something about that was really important for us, about us having the final say. And just quickly, just to kind of cover a few other things, where are we now? We're now moving away from daily reporting and moving to weekly. So our dashboard and weekly report will morph into a new way of reporting over the coming weeks. All the automated processes will remain in place, so they can be stood up again at a moment's notice. So if there's a resurgence of COVID and we need to do it all again, it's all there. But the point Ed made about not going back to old ways is really important for us. So we have established new ways of working, automation, use of R, and new ways of working for our analysts and data managers and epidemiologists. And we are now embedding that in the organisation going forward. So there's been great learning for us from COVID. We're looking to transform all our official stats releases, so much more use of dashboards and open data, and less use of lengthy PDF reports, which take months to write, but as I say, very few people actually use them. More automation, so we're using R, and we want to release capacity to focus on the so what of all the statistics that are produced. And then just quickly, I'm kind of conscious I might go over by a couple of seconds, hope that's okay. Just a highlight on what we do when we're changing definitions around testing or vaccination cohorts. We made sure that was communicated in advance. We produced statistical blogs and videos to explain key changes, and we trailed all of those in advance. And we did have close working relationships with all the other nations. So just remember that health has devolved, so our focus was on producing statistics which informed the Scottish position, but we did work with the 4 nations to attempt to harmonise where we could. And that was particularly true for vaccination statistics, where there was a lot of work in advance of publishing the vaccination statistics to make sure we were being common. And then just to kind of highlight that although it was great to see reference at the start to the governments, plural, often it feels like when we're talking about the UK that it's often referenced to Westminster and England. And I think there's lots to be learnt from all 4 nations. I think it's really important, really good that the RSS is recognising that in this particular session. I'll just flash up some kind of highs and lows, maybe just highlight some of the challenges. As an organisation doing this, it has been relentless. People are knackered, and so the staff wellbeing feature is a big thing for us just now to make sure people get a break. Sometimes the expectations of users have been unrealistic over kind of what's doable. And it's very, very high profile. So we've been very much in the eye of the storm with the media and parliaments over the entirety of the pandemic. But as I say, loads of highs, loads of new ways of working that we will be embedding as we go forward. So thanks very much. That's me, and apologies for overrunning very slightly there.
Thank you very much, Scott. We have one more 10-minute presentation. After that, we'll have around 15 to 20 minutes for discussion and questions. So if you're in the building, do think about what you might want to ask. And if you're watching us online, do put your questions in the chat. And our final 10-minute speaker is Barbara Bodinier, a PhD student in computational epidemiology and biostatistics at Imperial College London, who was a key member of the team on REACT, the major study led by Imperial and Ipsos Mori on how many people were infected with COVID-19. So Barbara, thank you for joining us, and over to you.
Thank you. Thanks for having me. So I'm Barbara Bodinier. I'm a third-year PhD student at Imperial, and I've been involved in the data analysis for the REACT-1 study under the supervision by Professors Mark Shadow-Hyam, Crystal Donnelly, and Paul Elliott. And I'm going to present today some of the statistical models that were used for the real-time monitoring of the epidemic within the REACT-1 study, and we'll show some of the results that were produced with the latest data. So this is an example of the typical results that were included in reports that were sent to the government and in preprints. So the REACT-1 study has been set up very early on in the pandemic, with data collection starting in May 2020. It has two streams, REACT-1 and REACT-2, and I'm going to present results from REACT-1 only today, which was monitoring the COVID-19 prevalence in the community in England using swab tests, so from May 2020 to early April this year. And I'm not going to present data from REACT-2 here, but just to mention quickly that this one was monitoring antibody seroprevalence in the community. The funding has now ended for REACT, so there will be no more data collection. So the data collection was organized in rounds, which took place roughly monthly over a period of 2 to 3 weeks. At each round, randomly sampled English residents were invited to participate by filling a questionnaire asking about their individual characteristics, whether they had experienced any symptoms, if they were shielding, and so on. And they were asked to send a nose and or throat swab. PCR tests were then done on the swabs to determine if the participant was positive to SARS-CoV-2 at that time. And for a subset of the positive swabs, we also had sequencing data to determine which variant it was. And we ended up with around 100 to 150,000 participants per round. The test results were obtained very quickly, which means that during the round, we had swab test results coming in every day for participants who had enrolled only a couple of days before that. And that data was then used to monitor the prevalence in the community in England in pretty much real time. So we had three main questions for this, which were first to have an estimate of the prevalence, second to look at the temporal and spatial trends, and third to track variants and sublineages. This data was also used beyond the real-time monitoring to get a better understanding of COVID-19. And in particular, I'm going to show quickly how we use the data to evaluate vaccine efficiency and to further characterize the most common symptoms. So the main objective of the study is to get reliable estimates of the prevalence. So the unweighted prevalence is calculated as the ratio of the positive swabs over the total number of swabs collected over a given period of time. And we can derive confidence intervals for the prevalence using a beta distribution. But not all the residents who were invited took part in the study. So to correct for potential biases arising here, we used rim weighting, which was done by our partner Ipsos, and that ensures that the weighted prevalence is representative of the population of England in terms of age, sex, deprivation index, LTLA, and ethnicity. So I'm showing here the unweighted and weighted prevalence estimates that were obtained for all 19 rounds of the REACT-1 study. One interesting thing to note here is that weighted and unweighted estimates are very close over the last 2 rounds, for which an incentive was actually used to increase the response rates in the underrepresented groups. And we have weighted estimates that go from 0.1% up to 6.37%, which was during the latest round in March 2022. And I'm going to focus on this latest round over the next couple of slides. So to get a more precise picture of how the epidemic evolves over time, we can model the daily prevalence that you can see here in figures A and B. The prevalence is modeled using an exponential growth model, as written here, where xt is the prevalence as time t and r is the growth rate. So from the growth rate r, we can compute the doubling or halving time, which is the time it would take to have a prevalence that is twice as large or as small. And you can see the growth rates r and doubling or halving times in figure C here. And we then used a Bayesian p-spline model to fit a smooth curve over the daily prevalence estimates, as you can see in the figure. And this model was developed specifically for REACT to account for the between round periods with no data. It helps in visualizing the temporal trends, and in particular, we can see that there is a steep increase in the prevalence during March 2022. So to look at this in a bit more details, we can stratify the data by subgroups, and in particular here, this is done by age class. We can see here on the left that we observed higher prevalences in children that were aged 5 to 11 years old over the 4 rounds that are displayed here. And we have higher prevalences in all age groups in round 17, which is January 2022, and round 19, March 2022. The temporal trends by age class on the right suggest that there is an increase in all age groups in early March, with a potential decrease in the youngest age group in late March, a potential plateau for the intermediate age groups, and a continued increase for the oldest age group. So now to look at the geographic trends, we used a neighborhood spatial smoothing model to estimate the prevalence at the LTLA level. So briefly, we randomly sample 15 participants per LTLA. For these participants, we calculate the neighborhood prevalence using their M closest participants, where the number M is chosen such that this is the median number of participants within a 30-kilometer radius. The smoothed LTLA prevalence is then the average over the neighborhood prevalences calculated for the 15 representatives of the LTLA. These prevalences can then be visualized over the map of England, and we can clearly see here again our 2 peaks in rounds 17 and 19 with the darker colors. And we can also see now that the prevalences were higher in the northeast and Birmingham and London in January, but higher in the southwest and east of England in March. Now, we all know that the peak in January was mostly Omicron, and that this variant has been dominant in England since. We can see it taking over here in the REACT data. And more recently, the proportion of BA2, which is a sublineage of Omicron, has been increasing in February and March. So using our daily prevalences of the 2 sublineages, we can estimate that it would take around 55 days for BA2 to be responsible from 5% to 95% of the infections. And as a comparison, this is slower than the Delta to Omicron transition, which took an estimated 29 days, but faster than the Alpha to Delta transition with an estimated 69 days. Finally, I just wanted to show quickly some work on the evaluation of vaccine effectiveness that we conducted on rounds 13 and 14, so finishing in September 2021. We obtained a vaccine effectiveness against infection at that time that was around 66%, which was calculated from a logistic regression with swab positivity as the outcome and vaccination status as predictor. And we could not properly estimate vaccine effectiveness in later rounds due to the smaller number of unvaccinated participants and their special characteristics in terms of behaviors, comorbidities, and so on. Another study that we conducted using this data earlier on during the pandemic was looking at COVID-19 symptoms. So this was done at the time using rounds 2 to 8, so ending in January 2021. And here we used a multivariable logistic regression model with swab positivity as the outcome and whether the participant had experienced a range of 26 symptoms, which were coded as 26 binary variables as predicted. We used the LASSO in a stability selection framework to identify the most relevant and non-redundant symptoms of COVID-19, and we ended up with a list of 7 common symptoms, including the 4 symptoms that had previously been listed by the WHO, so the loss of smell or taste, fever, and new and persistent cough. And we also had chills, appetite loss, muscle aches, and numbness tingling. So our model using these 7 symptoms had a better ability to identify positive participants than the any of the 4 symptoms approach that was used at the beginning of the pandemic. So to conclude, the REACT-1 data was used to provide estimates of the prevalence, visualize epidemic trends over time and space, and track the proportions of variants and sublineages in real time. So the study has been praised a shining example of random sampling, but despite this, the funding was not extended and there will be no more data collected. But still, there is much more left to do with this extremely rich data set beyond the real-time monitoring of the epidemic. And I wanted to thank everyone involved in the study, including the PIs, my fellow analysts, and the study participants. Thank you.
Thank you very much, Alvin. For excellent and varied contributions to get us thinking about the statistical resources available to governments. I'll come to people in the room for the first set of questions. We've got about 15 to 20 minutes, and then I'll ask Simon to summarise and put anything from online to everybody as well. So if you're in the room here at the RSS and you've got a view or would like to ask a question of our presenters, raise your hand now. Yes.
So I have one specific question, I think. The gentleman from Scotland, excellent piece he showed, but he commented at the end that he felt very much that the statistics in this country was dominated by England and Westminster. Being an Englishman, I share his view to some extent from the view of the ONS and because I would really appreciate it if Ed might comment on that one, because quite early on the CIS, I did make a complaint to the ONS people about the nature of the reporting on COVID. And in fact, I got a reply on a bank holiday Monday where I was requesting for better information on the United Kingdom from the national statistician. And I was told we were working on it on the bank holiday Monday. And I'm still awaiting the outcome of that working. And that's well over a year ago now. So I'd appreciate a comment on the Scots' view of our English dominance.
Shall I take that first, and then maybe Scott would like to supplement whatever I have to say? Well, I suppose I share Scott's view. I'm very committed, focused on OSR's work being UK-wide. I'd say some of our biggest interventions actually during the pandemic have been around the production of statistics, use of statistics in Northern Ireland, Scotland and Wales. What I find is that in Northern Ireland, Scotland and Wales, both the media and the policymakers and the users are very much aware of the England position, but the reverse doesn't hold. That the mindset in the media and policymakers tends to be rather England-centric in England. But I hope OSR is not victim of that. I've certainly given evidence to the Scottish Parliament And as I say, I hope we've kept Scott as much on his toes as we've kept the ONS on their toes and the HSC on their toes. So essentially, I share your frustration. I don't know if Scott would like to supplement that.
Yeah, thanks very much for coming through. Okay, so yeah, and Ed, you have kept me on my toes. So just to make that clear, and very much seen OSR's input as UK wide, and I think I wasn't so much as being critical about any perceived lack of kind of UK data. It's just that often when data is talked about from a kind of Westminster perspective, it's often referring to what's going on in England rather than UK as a whole, and I just think that kind of just making sure that we're kind of learning the lessons from all the countries that have been involved in responding to the pandemic, and that's why it's really good that I've been asked to come along today just to kind of give a reflection from what's been happening in Scotland. I think it'd probably be good to get kind of feedback from the other 3 countries as well, because they've all been doing brilliant stuff and we do all talk to each other. But just that sense sometimes that the good work in the other countries beyond England isn't always recognised because we're smaller nations. And I think there is learning that we could take from that. So that was really the point of my comment in relation to that. Rather than the data itself at UK level, it was more about that recognition that there's good work happening in the other countries as well. Thank you.
Can I just give one really great example of what Scott's talking about? Scott mentioned evaluation very briefly. Public Health Scotland and Public Health Wales have both done a piece of evaluation looking at the impact of discharging patients from hospitals to care homes. Now, that analysis is not without controversy. Some people have thought about it and maybe thought there were other methods available, but it's been done, it's available, it can be challenged and discussed and debated. To the best of my knowledge, that has not been done for England, that analysis of discharges from hospitals to care homes, the impact on outbreaks. Really good example of good practice in some parts of the UK not being transferred elsewhere.
Thanks, Ed, and thanks, Scott. And I don't know if any of our other speakers want to come in on that.
No, I wonder if I could just press both Scott and Ed on that a little bit, because I happened to stumble across the comments from Matt Hancock just a week ago in Parliament, because I gather there's a new health and social care bill going through, and the government has not sought in that to require the 4 NHSs to produce any common data. And I think he was rather concerned about that. And Jeremy Hunt echoed his views as well. Now, I realise, Scott, they're both 2 English ministers, but I wonder whether the Scottish view and Ed's view is that there is value in having a lot of common data between the 4 nations so that the experiences can actually be actively compared rather than having to rely on special studies using different data that's differently defined.
Yeah, shall I possibly come in on that one first, Ed?
Please do.
Yeah, no, so it's a really good point that's been raised. And I guess one of the challenges is because health and care are devolved, then obviously any kind of legislation that comes through Westminster is obviously focusing on England, and there'll be separate legislation that covers Scotland, Northern Ireland and Wales. So obviously that's the focus. So I can understand why the specifics around making sure we've got comparability across the UK isn't within that. But one thing I can say that has happened, actually, we had our first session last week, is on the back of our kind of joint working and joint dialogue over COVID. The heads of profession from the various organisations that produce health statistics across the UK did get together. We're now going to have a kind of monthly forum where we're actually talking about these very issues, about where can we get commonality, and also really importantly that where we can't get commonality because policy is different in the different countries, that we're really clear about kind of why you can't compare the different countries on particular aspects of care. So I would say that that's early days, but probably one of the good learnings from COVID, because particularly on the reporting of vaccination stats, we did and still do have a 4 nations group where we all join up to make sure we're all clear on each other's plans around reporting, so that we try and streamline it and kind of make the change as close to each other as possible. And I think taking forward that kind of approach and ethos, but it's just to highlight that the underlying data, the underlying data systems, the underlying policies are different across the 4 nations. So although it might appear that it's straightforward to make a comparable UK figure, that isn't always the case. But I think it's important that we do have that dialogue and try and do UK comparisons where we can. Thanks.
Could I just give a supplementary thought to that? I agree with everything Scott said. Those of you who are long-standing fans of OSR work, I believe there are some somewhere in the world, people who've followed our work down the years. We've been very focused on the issue of coherence of health statistics, but our biggest concern there has been coherence within England amongst the alphabet soup of NHS X and E and D and I and so on. And we've driven at that. And I think actually the pandemic has gone a long way to resolve many of those sort of complications. And it could well be that we lift our gaze then to the UK level as our next sort of frontier on this question. But I would say one other thing, which is I think we should distinguish between system delivery and population health. I think system delivery, there are different systems. The NHS, for example, is integrated with social care to different degrees by matter of policy between England, Wales, Scotland and Northern Ireland. And that does hamper comparison. But if we're interested in population health, I think it's going to be much easier to define comparable ways of looking at population health, because that's, to some extent, the institutional structures fall away and you're looking at people in households and in their lives and their health conditions. And I think probably that's the way to focus first if we're wanting to get a really good coherent focus across the UK.
Thanks, Ed. I'll ask Simon to summarise what's been said online shortly, but I think we've got 2 quick contributions in the room that I can follow on from that. Gentleman in the back row and then the lady in the front row.
Maybe I'm totally naive. Maybe I'm missing something. But it seems to me that the collection of health statistics is not a political issue. And that if there is a perceived need for UK-wide statistical collection, surely that's a job for the Government Statistical Service to do under its own aegis, to set the definitions and to avoid what seems to me to be somewhat over provision or overuse of presumably quite expensive resources around the UK. I can't understand why, and maybe I'm going to be controversial now, but listening to Scott Held's contribution, my mind kept coming back to 500 professionals in a country with a population of barely 5 million people. To me, there's something wrong if the GSS isn't collecting UK-wide statistics.
Thank you. And down here in the front row as well.
The concern about harmonisation is, I think, that we risk harmonising on the lowest common denominator. So it requires legal change in England, Wales and Northern Ireland to end the late registration of deaths in all nations of the United Kingdom, bar Scotland. Scotland does it right. The rest of us do it wrongly. A second point on, if you like, discrimination is why it is that the Office for National Statistics survey for Scotland has a sample size that is about 1/10 of the sample size for England. In other words, proportionate to population, when you are trying to address precision for a nation.
Thank you both very much for that. Simon, what else are people saying online?
There's a few questions that I am going to hold back until after the second round of speakers, because they are relevant to what's going to be said then. But a few comments here. One is that there was a variation in lockdown between the nations, a variation of lockdown at different times between the nations. And so far as I am, the questioner is suggesting there was no official data collected on that, which would have been quite helpful. And I suppose, is that true and was that right with the benefit of hindsight? Also got a question here from Sylvia Richardson, and as she's the president of the RSS, I have to read that one out. But this is to Adam and Ros, talking about the importance of getting the data early on the natural history of the disease and whether opportunities were missed. The example she gave in getting data on travellers back from Italy and how that affected. And it linked into another question that someone asked about how soon was it that we had real data available on asymptomatic, the importance of asymptomatic infection in this. And I had, yes, the final question was, and I think this might be for Ros and Adam, although any of the speakers also, a lot of the data in that very nice timeline chart you produced was not readily available to the public. And I just wondered if any of the speakers felt that more effort should have been made to get some summaries of those data to the public.
Thanks, Simon. Adam and Ros, I wonder if you want to come back first on any of those questions. We can hear from any of the other presenters if they have any views.
Yeah, go ahead, Adam.
I might just give a couple of brief thoughts on the first one, then over to Ros on Sylvia's. I mean, I think the question about evaluation of successive measures, I mean, I think that's something that's come up throughout the pandemic. And there was, with the event pilots, there was a scientific considerations piece published around, actually how do you design those trials and do the evaluation sample size. And I think a lot of countries have put things in and relaxed them without that sort of statistical evaluation. There's probably some missed opportunities there. And just, I mean, I'll just talk briefly as well to the final point about release of data. I mean, I think some of those platforms did very well about getting things out very rapidly. But I think one of the challenges early on is that a lot of the logistics just weren't in place. I mean, there were things, to sort of put together collection very rapidly, but actually converting those into nice dashboards or things that are very easy to use people. I think actually just getting the structures and the personnel in place for those did take, probably longer than it needed to in some cases. But over to Ros.
Yeah, no, thanks. I echo your points. In response to Sylvia's question, I think that this question of the travellers back from Italy or other very early cases and the opportunity to understand the natural history, that was at a time when there was a great deal of uncertainty about and a limitation of testing. But I think more could be done perhaps to repeatedly swab people, to bank samples for studies in the future, to try and understand those questions better, even if that banking is only for a few weeks or a month's time, in order to have the opportunity to analyze them. So I do think that the travellers from Italy came at a time when we didn't really understand the scale of the epidemic, both in Europe or in the UK. So it might have been unclear how valuable those cases could have been.
Thanks. Scott and Barbara, I don't know if you want to come in quickly on any of those points, or Ed, if you've got anything else you'd like to add.
Nothing to add from me, thank you.
Can I just pick up a couple of things? The point about the various flavours of lockdown and the collection of data. I think this goes to a point that I made very briefly about the contrast between thinking about things as an operation, set of operations to deliver, versus thinking about opportunities to evaluate. And I think the example of the test events was very good. They were very well designed, with sort of evaluation in mind. I think lots of the interventions weren't. And again, this is something that Sheila has corresponded with me about in terms of the use of lateral flow tests in schools, for example. So I think it is a very well-made point that is a lesson to learn, to think more about evaluation up front. The other point about the summaries of data to the public, I think it's a principle that we always had, was that if a data set was referred to by government, it should be readily available, the sorts of principles that Scott mentioned. And we sometimes found that where government was drawing, this is the London-based government, was drawing on data sets that were available internationally, for example, that it had scraped those data sets were not always completely accessible to members of the public, things like travel red lists and things like that. And that's something that we sort of pushed very hard on our sort of core principle of equality of access. So I think it's a very well made point about summaries of data to the public.
Thanks. And just to note as well, the one of the remaining RSS evidence sessions will be all about the evaluation of interventions and policy, so that will no doubt come up again. We're going to move on now to our sort of shorter contributions, sort of 2 to 5 minute speakers. We're going to start with a number of people who are here in the building, who will go up to the lectern to present. You can see that they are going to be Sheila Bird, Sean Richards, Tony Dent and Sam Clemens. And we're going to start with Sheila Bird, the distinguished medical statistician, past vice president of the RSS and a member of the RSS COVID task force. I think he's going to talk about test and trace statistics.
Yes, indeed. I chaired the RSS NHS test and trace panel. Fellow panelists were variously Simon Briscoe, John Deeks, Guy Nason and Jen Rogers. Now, DHSC official statisticians with whom we liaised were promoted and awarded, in which we took vicarious pleasure. The RSS panel brought epidemiological and data by design perspectives, together with a strong focus on transparency, because analyses of data held in the public interest should be in the public domain. So back in July 2020, the RSS's COVID-19 task force differentiated 2 types of high-risk contact of SARS-infected persons, those living in the same household and versus external close contacts. We advocated record linkage to discover how many of the identified contacts of each type tested PCR positive within 14 days, and we recommended 2 random visits to offer PCR testing to contacts and record adherence to self-isolation. Now, I'm pleased to say that by September 2020, experimental statistics based on record linkage were shared with the RSS panel, but release was not imminent. I wrote in October to ministers, no response until early 2021, and transparency took considerably longer. So the statistical team had done its job, the results weren't in the public domain. Infection control is influenced by the age group of the infected case, whether a child, adult or senior citizen, number of identified contacts, their age group and context within household or external, the viral load of the index case and of those infected. Now, despite statisticians' capability, official statisticians dealing with NHS test and trace performance were kept distant from tracking performance in terms of infection control, which was the whole point of NHS test and trace, which was disappointing to us and for them. Thirdly, the RSS panel asked repeatedly for a map of the NHS test and trace data sources, each with specified data fields, and how record linkage was operationalized, not easy, across those data sources. Why did we ask for that? Because such a data map is essential for understanding data acquisition and spotting gaps in the data that may need to be remedied ahead of new policy initiatives, for example, in care homes or for inter-laboratory comparison. And so why was it in September 2021 that the public and the press alerted to the immenser problem, that is a lab producing PCR negative results when they should have been reporting that they were positive, before the UK Health Statistics Authority seemed to identify it? Might have been they had identified it, but they hadn't told us. And even without PCR lab identifiers, the NHS test and trace statistics showed a highly significant decreasing trend over September in the percentage of PCR positive adjudications, which was perverse because the infections were increasing. Who missed spotting this trend? Finally, design and timeliness in monitoring the performance of new policies are handicapped if official statisticians are afforded little lead time. Hence, the Department for Education's failure to monitor the performance of 3 assisted lateral flow device tests within the first 2 weeks of English secondary pupils' return to school in March 2021. The RSS's Covid-19 task force had warned that due to the low prevalence of infection and only 40% sensitivity of the lateral flow device for asymptomatic testing, half of the LFD positives would be negative at PCR adjudication. And indeed they were, but it took another couple of months before we were shown the data that they were. And also official statisticians had not designed data acquisition to count pupils' school days lost following an initial lateral flow positive result, which would be before the pupil had actually gone into school, versus on one of the subsequent 2 tests, by which time their classmates were all contacts. Thank you.
Thank you, Sheila. Next up, we have Sean Richards, independent financial market commentator, on the impact of the pandemic on non-COVID statistical resources and data sources.
Hello, I'm Sean Richards and not Yes Man's Economics, and I'm going to give you some variety on 2 counts. One is people have been pretty upbeat about what things have gone on, so about to explain things went badly here. And the other is I'm going to switch to economics. Some of you may have noted that when the pandemic hit, the UK reported that GDP fell by 20.4%. This was extraordinary on 2 counts. One is the size of the fall, I think our biggest ever, although that's always an issue of debate. But then if you moved on to compare the international position, we did much worse than elsewhere. Our 20.4% compared with 10% in Germany, with over 10% in the US, 13.8% in France, Italy, 12.4%. So something was different in the UK. And it turned out one of the big issues here was a problem with the numbers. As it happens, I was, I think, the first to spot it, and it was in my arena of inflation. There's a secondary number that comes in here called nominal GDP. That was 15.4%. So if you just do a rough bit of maths there, that's telling you inflation's 5%. But there's a problem. CPI measure of inflation was 0.6. Even the RPI was only 1%. So it's time to look a little bit further. There is a number in the GDP statistics that actually goes through for the inflation figures and tells you where we stand. That was 6.2% for the quarter just on its own, 7.9% year on year. So very, very different to every measure elsewhere. If you go back to the time then, remember, this was in the phase where all prices were going negative. Every possible measure of inflation you could think of was somewhere around 0. Suddenly the UK was recording a lot of inflation. How has this happened? What's going on? Now, this comes to an area which other people have been talking about, or at least one of them was health. How's that measured? The second area was education, 2 areas that saw enormous changes. And the thing is here is how we came to measure this. I've been here many times before, and one of the words that's always caused it is the word improvement. Our word improvement in this thing, there's 3 ways of measuring GDP: output, expenditure, income. We've decided to go via output. The rest of the world virtually goes via income. So for them, there wasn't much change. Doctors were still being paid, teachers were still being paid, more or less the same. But for us, trying to measure actual output, we were in quite a mess. So what did we do? I told you earlier I had some high inflation numbers. I've got a bigger one for you now. Government consumption had inflation of 32.7%, when no one else was seeing any anywhere, in anything. And this was quite a shambles. When I was sent the thing for the questionnaire, when I would speak, and there were 5 things you could speak about, mine qualified on all of them, because we couldn't compare to anywhere else. It's entirely clear we could even compare with ourselves. And things were, as you can see, in quite a state. If we break that down, we can say that there are issues around education at the time, 34.4%. Come to health, which has been what most other people have been speaking about here, 36.1%. So there was an enormous change in the system in the UK due to the way that we tried to measure things. The people that did it were unlucky. Who knew that there was going to be a pandemic and would cause the things that it did? But as you can see, there are a lot of big shifts. And why this was a subject warm to me is some years ago, I given some advice, technical advice, to a bloke called Pete Comley, who wrote a book called Inflation Matters. And I remember one of the things he said to me was, Sean, they make up the government sector numbers, don't they? And here we are. Thank you.
Thank you, Sean. Our next quickfire contribution is from Tony Dent, the founder of the Better Statistics campaign on the COVID infection survey.
Thank you, Chairman. I'd like to briefly address two of the issues originally mentioned in the call for today's meeting. They are the COVID infection survey, which I would prefer to call the CIS if I know in future, and also open data and transparency. I link the two because, in my opinion, the cost of the CIS at around £1 billion has not been value for money, and at least more value could have been obtained if access to the data had been more widely available at an earlier time. Beyond the issue of value for money, the request for contributions to today included whether there was any alternative to the CIS and what should its future be. Unfortunately, I don't have the time to discuss those two issues here, but allow me to say that I do think there are alternatives, and therefore I think it should only continue in a much reduced and modified form. So I'd like to return to the value for money, if I may. In this case, the ONS really subcontracted all the work to an organisation called IQVIA. And the response rate, sadly, has only been 13%, despite the fact there's been very high incentive for contribution, £50 for each person registering, plus £25 each month they continue to do testing. Very good for elderly pair couples. Anyway, this incentive has cost something like 25 to 30% of the total cost. So it's been very high. It's rather surprising to me that with such a large incentive, we should have such a poor response rate. And as luck would have it, recently, this week, the United Kingdom Statistics Authority has published the survey on public confidence in official statistics conducted by NatSen towards the end of last year. And it's a very interesting document because it demonstrates, or it informs us, that the public have a lot of confidence in the Office of National Statistics. It's actually gone up in the last 2 years. It's in the order of 87%, plus other things. And it really is a very great surprise to me that people who have are being encouraged to do something which is nationally extremely important, we should only get that kind of response rate. I might say, by the way, that the survey conducted by NatSen took place over a 2-month period, or nearly 2 months, from October to December last year. And there was an incentive there, a £10 voucher. And of course, the survey is much easier to produce for only 40 minutes, whereas contribution to the CIS took a lot more time. But goodness me, wasn't it so much more important? So I really questioned value for money, and indeed, in fact, I questioned value for money for the recent SEN survey. That says a lot of point. Thank you for your time.
Thank you, Tony. Our final in-person quickfire talk is from Sam Clemens, Research Director at Ipsos Mori, on what market research can offer in future pandemics.
Hi, thanks, Gavin. So I'm Sam Clemens from Ipsos, and as Gavin said, I'm going to talk on what market research can offer. So obviously, as we've heard from today, this pandemic has highlighted the need for sort of high quality and timely data. And research agencies like ours were able to use existing products and tools such as our range of online panels, as well as use our knowledge and our infrastructure to help set up new studies. So we helped to ensure that the big surveillance studies actually could take place. We were the logistics partner for REACT, And our face-to-face fieldwork team played a key role in the COVID infection study. And just as an aside, I'd like to point out that on React, we actually managed to get better response rates without incentives, but that's a slightly different story. What I wanted to point out is it wasn't just the big surveillance studies that we were able to help with. There was a lot of smaller scale research we did that helped people to make decisions at a slightly smaller or lower level than the big major decisions that were going on. Some examples are we did some social media research that assessed the effectiveness of public health communications. We used our random probability online panel for a load of surveys. For example, we did a longitudinal study looking at attitudes and behaviours to vaccine take-up, and particularly focused on those people who were nervous about vaccines to try and work out how you could address their concerns. We did digital ethnography. We produced life under lockdown video diaries, and that enabled policymakers to sort of hear real stories from real people. Also, being an international company, we were able to do global research. So we had a big tracking study that covered North and South America, Asia, Europe, South Africa, Australia. And as early as February 2020, we were producing briefings for our clients, looking at things like levels of concern, the impact on people's lives and finances, people's behaviour, their expectations for the future. And that meant that policymakers could sort of see the impact that the different governments' approaches had on their populations. So I think that market research companies are well set up to provide timely and high quality data of the sort that policymakers who are making decisions about stuff do need. And I think we have shown in this pandemic that when the need arises, we can also produce that data extremely quickly.
Thank you, Sam. We're now going to go to some quick-fire online contributions from Ross Clark, Peter Wells, Matthew Edwards and Denise Leavesley. So we're going to go first to Ross Clark, journalist at The Spectator and elsewhere, with a journalist's view of the problems with the data. I think you may be on mute, Ross.
Hello, can you hear me now?
We can indeed.
Yeah, okay, yeah, Ross Clark from Spectator, Daily Telegraph and so on. For me, the biggest problem was the publication of daily death figures without the context of who was dying, age, other conditions, whether they died of or with COVID, and also any comparison with the number of deaths which would be expected anyway in an ordinary year. I remember one widely reported claim, and this was based on an ONS release, that 2020 was the deadliest year in a century, with it only being explained low down in the news stories that this was simply a raw measure of the number of deaths, ignoring the massive population growth in the intervening years. The ONS was publishing figures for excess deaths once a week, which ought to have been more enlightening. But there was a problem with these figures too. The number of deaths was being compared with the 5-year average without adjusting for population growth or aging. Given that the number of over 70s is rising by around 2% a year, thanks to the post-war baby boom, you would expect the number of deaths to rise over time, even without a pandemic. The figures that I thought most illuminating, but very little reported, were those for age standardized mortality put out by the Institute and Faculty of Actuaries, which were adjusting for change in population profile and revealed that rather than being the deadliest year since 1919, 2020 only took us back to the mortality rate of 2008. But this was a privately published data set. Neither the ONS nor any other public body, to my knowledge, attempted anything similar. Just one or two other things. There was a problem, I thought, with the presentation of graphs, which showed peaks and troughs in the number of confirmed cases without it being explained, often in government presentations. This figure is partly a function of how many tests were being undertaken and how many of these tests were actually being reported. Hospitalization figures throughout the pandemic did not distinguish between people who were in hospital because of COVID as opposed to those who caught COVID incidentally while they're in hospital, until government advisors began to make this clear some way into the Omicron wave. And finally, very briefly, I think there's a big problem in the presentation of modelled scenarios and a failure to distinguish between modelling and real data. What was happening is that a modelled scenario would produce the extreme worst case, and that would end up being presented as a forecast. The people putting together the press briefings may have made this point in passing, but they ought to have been aware of how the extreme scenario would end up being presented as a forecast, and they didn't take this into account, I thought, while presenting the data. I mean, the infamous case being the 4,000 deaths a day graph presented in the Halloween press conference on 31st of October 2020. So those are my thoughts anyway. Thank you.
Thank you very much, Ross. Our next virtual contribution is from Peter Wells, a freelancer who does politics, policy and delivery to try to make data and technology benefit everyone on the availability of data locally. Hello, Peter, over to you.
Thanks, Gavin. Hello, everyone. I'm Peter Wells, and thank you to the RSS for the opportunity to speak. Just one thing to add to that intro, I'm also a committee member on the RSS's Data Ethics and Governance section. So, in the pandemic, there were a number of decisions to be made at the level of England as a nation, where to send PPE, where to add hospital capacity, or what non-pharmaceutical interventions to put in place for us all. And there were a lot of data collection, statistical processes, such as those in NHS Test and Trace that Sheila mentioned, that were put in place to meet those national need. But there were also decisions to be made locally, where to advertise new guidance and rules and in what languages, where to place testing sites, which workplaces needed stronger enforcement. And in pre-pandemic times, local authorities were responsible for many aspects of public health. They worked with the NHS and a range of partners such as care providers, police forces, charities, businesses, community groups, individual citizens to deliver public health, the kind of partners that help make and implement those local decisions for other public health issues. But for many months throughout the summer of 2020, they lacked data about the pandemic, as the data collection, statistical processes, prediction processes did not meet those local needs. As a result, decisions were not made or were made with lower levels of evidence than could otherwise have been the case. Local capabilities that could have helped with the pandemic were underused. And as a result, some places started collecting their own data. Businesses started selling proxy data collected from non-healthcare services to local authorities. And this was different data than that already existed in the public sector that was being used by the national government in London to make decisions about England. Now, those differences, they also create some opportunities to evaluate which methods work better and also cause some trust issues between national and local government, but I only have 2 minutes. So if, as well as prioritising national needs, there had been a greater emphasis on local needs for data and statistics, a greater emphasis on strengthening and using those existing capabilities, we might have had more effective local responses to local outbreaks, and that could have saved more lives to the good of everyone. And I suppose looking ahead beyond the pandemic, it may also help with other policy goals like the levelling up agenda, but that's probably a future evidence session that I look forward to the RSS arranging in a year or two's time. Thanks, Gavin. Back to you.
Thank you very much, Peter. Our next online contributor is Matthew Edwards, who comes from somewhere you heard Ross mention, who chairs the Continuous Mortality Investigation under the auspices of the Institute and Faculty of Actuaries, who have a long history providing authoritative and independent mortality and sickness data. Matthew, thank you for joining us. Over to you. I hope we've got Matthew. If you're with us, you're on mute at the moment.
Is he online?
We were doing so well.
Should we play the next one?
We will go instead to the next contribution, which is a... Oh, we've got Matthew. Excellent. Hello, Matthew. Welcome.
Oh, hello. Sorry, I was blanked out, which is a good thing to do with actuaries. So thanks very much for inviting me. Apologies for being remote. I'm very glad to, first of all, to be speaking here. One of my uncles is a fellow, so it's a great honour to be having some sort of connection. And I'm very glad also to be following Ross, because in fact Ross outlined a number of things which effectively we over at the CMI I think we've pretty much solved. So the CMI, I'm here as chair of the CMI, the Continuous Mortality Investigation part of the Institute and Faculty of Actuaries. Just wanted to outline what we had done as our sort of excess deaths monitoring over the last couple of years. So by way of background, we had been starting what we called a mortality monitor 2 or 3 years before the pandemic, taking quarterly ONS deaths data and thinking about that and how it fed into actuaries' views of mortality improvements. So at the start of 2020, with all the problems, we thought it would make a very good basis to build on to create an excess deaths reporting methodology. And it seemed clear to us that we needed to, well, society needed to have a very clear picture of the deaths from the pandemic, and that there are clearly going to be problems with the two basic measures of deaths, the ONS measure based on death certification and the PHE measure based on recent positive tests. So the excess deaths seemed to us to offer a very valuable adjunct to that, and at the beginning would likely be more reliable. So the excess deaths is basically an actual minus expected construction. So actual deaths minus expected deaths. Everything therefore hinges on how you define expected deaths or how you calculate expected deaths. And two key things there we think we added a lot of value. One is the age standardization. So as actuaries, age standardization, also age and gender standardization is just second nature. It's a no-brainer. So everything we did was on an age and gender standardized basis. So taking account of some of the sort of distortions that Ross implied were present in other statistics. And the other thing was thinking of a sensible baseline. So as actually we spend half our lives thinking about improvements, and we might have thought we should go and model the improvements up to 2020, so model expected 2020 mortality using some of our models. In fact, if we had done that, that had been a much greater communication problem, trying to communicate how we'd constructed that expected baseline, which would then open our figures up to challenge. And we're very keen to have sort of non-challengeable, sort of easily defendable data. So we decided not to try and model improvements and just to take the most recent year that seemed to offer a good baseline representative of expected 2020 non-pandemic mortality. So for that reason, we took 2019 mortality. Now 2019, the first 2 months or so of 2020 had mortality very close to 2019. So just on that basis, it seemed close, but also it would have been the default option because mortality pre-pandemic has been increasing materially year on year for pretty much every year since the Second World War or thereabouts. So for us, the clear default option was just to take the previous year before the pandemic as the baseline. You might argue from a statistical perspective that if you take 3 or 5 years or whatever, you'll have a more data and therefore less volatility. But in our view, given that monotonic movement in mortality from year to year, with population level data, there's very little volatility. We're just sort of breaking down by age and gender, and that tiny volatility is fine to sort of better than the distortion which would be implied by taking a 3 or 5 year average and therefore hiding the mortality improvements implicit in that period. So age standardized excess mortality calculation with 2019 as a baseline. Extremely useful, we think, in early 2020 when the two other metrics weren't particularly reliable, then became very reliable since then, just as another baseline, another metric. And over the last year, 2021 and now in 2022 has also been very useful as a way of seeing the impact of the pandemic, so if you like, net of the various different influences. So obviously the direct COVID-19 deaths, but also some of the other aspects, such as the allowing for the forward displacement death, whereby many of the 2020 COVID-19 deaths would have been deaths of, if you like, lower normal health than usual, and hence would have, if like, disappeared from the pool of 2021 deaths, if you follow my logic. Statistically, there weren't very many sort of subtleties or nuances other than there's a couple of basic points to mention. So bank holiday weeks, there's a bit of sort of manipulation to make sure the bank holiday reporting wasn't distorted. There's quite a lot of attention to our communication because we're normally used to communicating with actuaries, as you might imagine. So in our press releases on the mortality monitor, we had to be very careful with the language and be quite aware that there is, clearly in 2020, there's an intensely sort of political debate around deaths with COVID, deaths from COVID, or whatever. So we had to be very careful with our language and our communication to make sure that our messaging was correct and clear and was not going to be taken by groups who might have been keen to use it to misinform. So those are really the main points. So hopefully that's been a useful summary, and thanks again for inviting us at the CMI to present what we've been doing. Thank you.
Thank you very much, Michael. And our final quickfire contribution is a recorded video from Denise Leavesley, former president of the RSS, who comes with an international perspective, including on COVAX, which is the international initiative to accelerate the manufacture and development of vaccines.
Thank you to Simon and the RSS for the invitation to speak at this meeting. Please accept my sincere apologies that because of a clash in my diary, I'm having to record my contribution. But in these few words, I want to ensure that the international focus of the analysis of our COVID performance is fully recognised. After all, COVID is a global pandemic. There are two statistical aspects to our international role. The first concerns the measurement of what we have contributed to other nations. One heard the mantra, "No one's safe until everyone's safe," repeatedly. But was this merely rhetoric? Our government pledged to deliver vaccines to poorer countries, but were these promises delivered upon? It seems to me that numerical targets are too often treated as if they're an end in themselves, and too rarely is there adequate monitoring of them. I'm reminded of Goodhart's law: when a measure becomes a target, it ceases to be a good measure. How many vaccines did the UK to donate to other countries? And was this achieved in a timely way? One heard that some richer countries dumped vaccines close to their use-by date on countries with inadequate mechanisms to use them quickly. Is this true? COVAX was established to accelerate the development and manufacture of COVID-19 vaccines and to guarantee fair and equitable access for every country in the world. What role did the UK play in supporting COVAX? Did our preparedness to pay relatively high prices for vaccines impact negatively on those in nations less well off? Was our decision to give 3 or even 4 vaccinations achieved at the expense of those who'd not even had access to 1 vaccination? The regular UNICEF COVID-19 vaccine market dashboard paints a picture of a very uneven world, one we should be ashamed of. The second issue I want to raise is the use of international data to learn from the experiences of other countries. I returned on Friday from the biennial International Congress on Official Statistics, which was held in Poland. The Director General of the WHO gave a presentation at which he thanked statisticians for their critical work during the pandemic. And we were urged to continue to share quality, cross-nationally comparable information. Indeed, on May the 5th, the WHO will publish a report on excess deaths across the world. I hope that we'll use these data in the spirit of building an understanding of what the UK could have done better, though I do fear that the use of league tables of countries' performance engenders defensiveness. It's really gratifying when sharing international experiences allows us to celebrate good practice. An example was Sarah Croft's presentation last week in Krakow on the ONS prevalence survey, where she talked about the policy relevance of those data and mentioned the strong relationship built between academic and official statisticians. The speed with which that survey was set up is also a reason to be very proud of what we can achieve as statisticians in the UK. And I want to end on that positive note. Thank you.
Thank you to Denise. As I said, we've got about 15 minutes left. So again, I'll come to the room for any contributions first. Please do keep them short. I'll then go over to Simon to see what's happening online. And I suggest that if any of our online presenters want to come in at any point, if you use the raise hand tool on Teams. So let's start with anyone in the room. Any thoughts, questions, contributions? Yes, if you could just wait for the microphone for a second.
Thank you. I was interested in the REACT presentation, that some of the extra symptoms that have been added to the initial few that WHO have been using. And of course, we got the ongoing Zoe symptom study, which is self-reported data. And I think that's probably one of the few things that's actually continuing now. And just to sort of mention 2 points about that, it's only in recent weeks, I think since April the 1st, that the UK government's even taken up some of those extra symptoms. Of course, they're common to other ailments, but it seems to me that going forward, there's a resource there in that kind of citizen science project, but also a need to try to incorporate that retrospectively, bearing in mind it's a different type of study from the ones that we've heard about.
Thank you very much. Anyone else in the room want to share anything? In which case, Simon, what's happening online?
So I've got a few observations here, which some are directly following questions that have been raised, other are sticking various observations together. Richard Potter was picking up on what data we might need, the discussion earlier about what data we might need at a UK level. And I suppose the question there is who decides and who produces it. And there was a contribution from a gentleman at the back suggesting that the GSS should be quite forceful in that. So I don't know whether Scott or Ed have a comment on that, but that would be an observation. A second question was asked about the positive that came out of the pandemic as far as data is concerned, which is there's a lot more data linkage than there used to be. And I suppose it's easy to discuss whether we think that will continue or whether now there is more data linkage, that there will be a lot more happening in the future, or whether it sort of goes into reverse. But I suppose I'd be curious to know any of the speakers' observations as to why that sharing happened, because it was always the sort of perhaps cliched response that was departmental lawyers' sense of nervousness, which I can't imagine has all of a sudden gone away, or concerns about ethical issues, which also I can't imagine have gone away. So I wonder, what is it that's driven or enabled that extra data sharing? And then there was a question that someone picked up on what Sean said about the education picture. And I suppose here I've summarised it as what is the overall picture. So the GDP numbers and the teaching figures suggest less actual teaching was done during the pandemic, and yet mental health of children has apparently deteriorated. And yet, of course, famously, the exam results were all very much better. And I suppose the question is, should anyone be trying to pull this together to give an overall picture of what the statistics about education actually are telling us about what's happened in the last couple of years? I've got a couple more, but I'll stop there in case that's provoked any comments.
Thanks, Simon. And again, if you're one of our online contributors, do raise your hand on Teams if you'd like to add anything to that. Ed, I don't know if there's anything you want to pick up on that.
Well, actually, can I pick up all 3 of the points raised by Simon's summary of people's comments? Because I think they're all good and interesting. Sort of in reverse order, I think the point about education impacts and the balance of lost learning, mental health impacts, how that's flowed through into attainment in the exam system, I think that's a really, really important area. The British Academy have been talking about this being a COVID decade, not a COVID couple of years, and I think tracking those sorts of impacts through is a really useful thing to do. We've been doing some work on statistics and data on children and young people that is encouraging producers to focus on this sort of question. It's a much more rounded picture as opposed to individual sort of aspects of the problem. On data linkage, I think the brief answer is well, of course, for some parts of the UK, and Scotland might be a good one, but there's always been more openness to data linkage than there has in others. But I think what made the difference in the pandemic actually was, as much as anything, political will for it to happen. And I think the real test will be the extent to which that remains a driving force, or whether it unfortunately might dissipate in the face of the kind of barriers, Simon, that you mentioned still perhaps being with us. And on data at the UK level, I think the challenge was to be more forceful. I think that's a good challenge. That's a good challenge that I and statistical system should take up. So thank you.
Thanks, Ed. We've got a question here at the front as well.
There's not a question, an observation about data linkage. It's just evident, I think, to me, from watching what's been going on in recent years, that data linkage is a key area for the ONS and our statistics service, and one pursued by the government, given a lot of long before the pandemic. And I think the pandemic's just benefited from a political will and a statistical will to access administrative data of all kinds and relate it. And partly it's seen as a cost-saving exercise. If we actually sort of access more of the administrative data, maybe we don't have to go and talk to people about what they behave. We can actually observe it from and get Google to tell us about people. We don't need to go and talk to them. So I'm suspicious of this advance, as you will see, but it is a political will, I think, which the benefit the COVID the pandemic has to some extent benefited from. People have been stuck at home anyway.
Thank you. Anyone else in the room have anything they'd like to add?
Can I come back on the third question, as it was partly to me, on the issue of education?
Yeah.
And the fact is here that, as I explained at the beginning, part of the problem is you're going to go for a GDP output measure. How do you measure education? So we've ended up in a situation whereby we've got, as a sort of gold standard, if you like, that you then say, how was in the school good? How much better are they than online? Does anyone actually know? No. And so we ended up with all these distortions as we were trying to chase our tail. And compared to go back to the international thing, as I said before, which stuck on the income level, so teachers were still being paid, presumably trying to do their best. The flaw in that, of course, that there was a change that they're missing. But it is a complicated area, as Simon pointed out. The exam results were better. So there are a lot of big questions about this that go way beyond the economic sphere and trying to measure it from there. And you end up trying to define what is education for, don't you? What's its purpose? How are we going to take that forward?
Absolutely.
May I ask whether the Institute of Actuaries, in doing their age sex adjusted expected deaths, base their comparisons on the date of occurrence of the death or the date of the registration of the death? Because you mentioned registration delays over bank holidays and so on.
Yeah, yes, thank you for the question. It was one of the things on my script which I omitted for reasons of time. It's a very good question. Date of reporting or date of occurrence. So a lot of our, if you like, real work we do on date of occurrence, because clearly that's the real data as opposed to reporting. The weekly monitoring we were generally doing on a reporting basis. And the various times we need to think about what we call IBNR, incurred but not reported, to allow for that delay. But we think we sort of took the right approach here, just in terms of needing to deal speedily with data and deal with the most recent data available. So most of our work here was done on the reported basis.
Great, thank you, Matthew. You've all taken my words to keep things brief, very much to heart. Does anybody in the room or online have any final thoughts they'd like to share with us? And I will go to Ed.
Is that okay? Is it? Am I allowed to?
You're allowed to.
Okay, thank you. I just wanted to comment on some of the points made in the 2-minute slots. I thought Sheila gave an excellent and extended articulation of the points I was rather clumsily making about the need of thinking about not just operational delivery but evaluation. Your examples were fantastic for that. I think Sean's point actually opens up a whole new set of issues around statistical resources, which the RSS should probably consider a separate session on the non-health data related issues. I think there's a lot in that, and we can scarcely do them justice. And then I think Tony, Ros, Peter and Matthew all gave really good accounts of why non-official data sources are a really important contributor to our understanding of things, and we should celebrate the fact that we have this really rich sort of system of people who are doing a range of really fantastic things, not just the official statistics, and that's not to be kind of held at arm's length. It should be embraced and really respected, I think.
Thanks, Ed. And that may, Simon.
Yeah, I was going to raise one question, but just picking up on Ed's point, last point, I think that's very fair. But if Denise says that the WHO are producing excess mortality figures this week, The Economist magazine, I think, has sort of been the benchmark for international comparisons throughout this. We've got the CMI figures that Matthew represents and the ONS figures. Inevitably, all four will be very different in terms of presenting the UK nations or the UK in total, and where the UK is in the pecking order. So I do wonder who it is who's going to look at those and sort of arbitrate between them. I'm not expecting Ed to answer that. Being at the top table, he's ended up having to take more questions. The other comment I was going to ask, which I had been meaning to ask, was really of the market research community, not necessarily one for now, but maybe later, is that if I'm right in thinking the CIS was almost unique in its form in the UK. No other country did the same sort of thing, and therefore, as Denise and others have said, it's been widely praised, not forgetting some of the criticisms that Tony Dent and others have of it. But I do wonder if there are other examples of excellent bits of market research that occurred in other countries that the UK could have benefited from or copied from. And that's not necessarily to prompt a response now, but if people can email in any thoughts on that, and really to thank people for posting the links in the chat, because there's quite a few sources of data and useful observations in there.
Thank you. That feels like a very good place to end it. All that remains for me to say, first of all, remember this is one of 4 events. You'll be able to watch this back on the RSS website, along with the previous event on government communication during the pandemic, but also keep an eye on the RSS website and sign up to the mailing list to find out when the next 2 sessions will be on how evidence and decision-making inform policy, and on the evaluation of interventions and policy. All that remains for me to say is a series of very, very big thank yous. First of all, to our fantastic speakers today, to Ed, Adam, Ros, Scott, Barbara, Sheila, Sean, Tony, Sam, Ross, Peter, Matthew and Denise. To everyone here at the RSS putting this together, particularly Teresa, Erica, Alfie, Jonathan and Slian. And of course, a huge thank you to all of you watching us online and to all of you watching us here as well for some fantastic questions and great discussion. Thank you very much indeed.
Thank you.